Thank you for joining me here at the 2020 Sean McDiarmid Summer School. It's a great honour to be invited to give this talk, and I want to say a special word of thanks to Regina Fahy and to Kate McCarthy, with whom I have worked and they have worked very closely with me in bringing this about. Regina will be returning to chair the questions at the end, and behind the scenes Kate is dealing with all of this very complex technology, so thank you to both very much indeed. My talk is to do with psychiatric healthcare in Ireland, with a specific focus on the impact of COVID-19. This of course took us all by surprise, and it is difficult to judge what the long-term impact will be, but I'm going to have a go at the end. I want to thank all of these people whom I work with in the Mater Hospital for their help in providing me with information and some basic statistics, and for their interest and encouragement in my involvement in this. There is a plan to the talk, and it's up here on screen for you. I'm going to talk firstly about the basics of the psychiatric services and how they were funded and the problems associated with them, just to give you a sense of where we're starting at. I'm then going to talk about clinical stuff, the mental health problems that have arisen during the pandemic, and then finally the third part will deal with what the post-COVID mental health problems are going to be like for a number of stakeholders involved in this whole pandemic. So psychiatry has euphemistically been called the Cinderella of the medical services, and when you look at the funding and the budget that we get, you can see what's meant by that. In 2018, the mental health budget formed 6.6% of the total health budget. In 1985, 35 years ago, it was 13%. It was double what it is now. Notwithstanding the fact that our population has grown, the mental health problems have become more difficult and complex, mainly due to the influence of illicit drugs, and just we live in a more complex society. So the government commitment to mental health, judging by the budget, is declining. In 2018, the budget that we were then given saw a 10% reduction in the budget compared to 2009. Currently, there are 472 consultant psychiatrists across all the subspecialties in Ireland, but the Hanley report in 2009 recommended that by 2016 there should be almost double that amount. But to add to our woes, there is now a huge shortfall even in the existing posts. 20% of them are unfilled, and of those that are filled, 30% are locums. The shortfall in the psychiatry of intellectual disability is 68%, so it's huge. It's almost 50% in child and adolescent psychiatry. It's 42% in psychiatry of older people. And in general adult psychiatry, which is my specialty, there's a 22% shortfall in consultants. So nowhere across the disciplines of psychiatry is there a full complement of consultant psychiatrists. I'm not going to touch on the other disciplines here because there just wouldn't be time, but there's a shortfall of clinical psychologists, of psychiatric nurses, of social workers, and of ancillary of counsellors. So across the board, there are problems. We also have a shortage of inpatient beds. Now, I have to emphasise that virtually all people with mental health problems who need inpatient treatment are treated in psychiatric units in general hospitals. The institutions, the big mental hospitals, forbidding places that we know of from the past have thankfully gone. We have 34.8 inpatient beds per 100,000 of the population, and it is the third lowest in Europe. It's lower even than Albania. So the basic infrastructure is a huge problem in psychiatry. And it's relevant here because if we're looking to what may happen in the future when the COVID virus is under control and we're all running our services as we did before it, we have to bear these shortcomings in mind. We have a huge waiting list problem as well, particularly for children and adolescents. And 2,700 are now waiting to see consultant psychiatrists. More than 400 are waiting for over a year. And there are 6,000 waiting to see clinical psychologists. And of those, 1,600 are waiting for more than 1 year. So this is there's a huge backlog of people who are suffering emotionally, who cannot get the treatment that they so desperately need. Now, among patients at the moment, both outpatients and inpatients, well, when I say at the moment, I mean before COVID, but up until, say, the end of February, beginning of March, the main diagnosis that we saw in people were depressive illness, which is probably the most common, although it may be overdiagnosed. I can take questions on that later on. But depressive illness, stress reactions, and in that group we have a condition called adjustment disorder that I'll be mentioning. So stress reactions. Substance misuse is a huge problem, particularly in our young people. Drugs, illicit drugs, as you all probably know, are in every town and village in Ireland and probably in every secondary school as well. Generalized anxiety is another big problem. Conditions like bipolar disorder and schizophrenia are less than 1% in the general population, but of course are higher among inpatient and outpatient populations. Probably among inpatients, they would be of the order of 30 to 40% of the people. So they would be much higher among inpatients because these are the most serious illnesses and they invariably require psychiatric admission for a period, particularly if there's uncertainty about the diagnosis. They need a period of assessment as an inpatient or for treatment of acute exacerbations. And most of those acute exacerbations are due to people abusing illicit drugs on top of what they already take and are prescribed, or not taking the medication that's prescribed for them. And then the other condition that we see quite a bit among psychiatric patients, both inpatients and outpatients, is a condition called emotionally unstable personality disorder. And they are particularly common in people who self-harm, people who take frequent overdoses, who cut their wrists, or sometimes other parts of their bodies, who in response to relatively minor stressors become unwell and their mood becomes destabilized. So these are the most common conditions, but the most serious, of course, are schizophrenia and bipolar disorder. Now, if we move on from psychiatric units in general hospitals and look at the rest of the general hospitals, people up in the surgical wards and the medical wards, they too get referred to psychiatry. And I'll come to the figures for that in a moment. But in that group, the main diagnosis is usually adjustment disorder, followed by depressive illness and anxiety states. So again, we're dealing mainly at the somewhat milder end of the spectrum. Most people coming in with medical and surgical problems don't have schizophrenia or bipolar. Obviously, some do, because it's out there in the population, and they are just as likely to need to have their varicose veins removed or to need a cardiac stent as anybody else. In fact, probably more likely to. So we will see some of that group in the inpatient general hospital population, but not to the same extent as in the psychiatric units or in the outpatient clinics. Now, here's some data for you. In terms of self-harm, we now are collecting very good data because there's a national self-harm registry which has been going for about 10 years. So we have a lot of information about this group. Every single hospital in the country now has very well trained clinical nurse specialists in self-harm who see and assess every patient who comes through who self-harms. The self-harm might be an overdose, it might be a cutting, and at the moment it doesn't include people with suicidal thoughts but who haven't harmed themselves, but that is probably going to change, and that is going to be added in due course. So what kind of data are we talking about? And I'm only talking about the Mater Hospital. Nationally, there are about 11,000 self-harm, 11,000 people who self-harm per year. In the Mater Hospital, which is the largest, we have the biggest throughput there, it's 550 people per year self-harm and come to the Mater Hospital, each of whom is assessed and has a full biopsychosocial assessment by the trained nurse. What happened then when COVID struck? What happened to self-harm people? Well, it dropped to a trickle. It dropped 3 or 4 per week, from 10 to 12 per week down to about 3 or 4 per week. And sometimes there were none at all. For the first 3 to 4 weeks from mid-March onwards. The first week or two in March were, the same numbers as usual. That was before COVID began to play havoc. Then when that happened, people weren't coming to the emergency departments at all. And one of the reasons for the drop here may have been just that people were still harming themselves and taking overdoses and getting suicidal thoughts, but not showing up because they were simply afraid of getting the virus. But I find it difficult to believe that the large numbers of people who take serious overdoses and who cut themselves seriously, not just scratching, but who actually cut themselves deeply, would simply be staying at home. We know they weren't going to their GPs, because I have spoken to the GPs, the senior GPs around the country. They weren't seeing them either. So it may well be that this group, who are often the group that have the emotionally unstable personality disorder that I mentioned, that they were actually able to contain their distress and their impulsivity, because they are an impulsive group, but that they were able to contain it for a few weeks. And then in mid-May, we saw a surge. And that was reported widely in the media, that there was an increase in people presenting again to St. John of God Hospital and to the private sector. And we certainly saw it in the Mater. And again, other units that I rang round to had the same experience. Other emergency departments had the same experience, that there was a surge. And that has dropped slightly again in the few days. The surge may have been because people could no longer cope with the lockdown and the restrictions being placed upon them. It also may be that the drug dealers came back into the centre of the cities again. And a lot of these overdoses are with illicit drugs like cocaine. And alcohol is thrown in. So it may be that the drug dealers coming back into the centre of the cities led to this surge. We just don't know, but they're my theories. There has been a slight drop off again in the last few days, probably as the government kept emphasising the importance of social distancing, and there were certainly quite a few guard the patrols on roads. So this is a very interesting group, and they will be studied in more depth when we get information after the lockdown is over. Now, this slide has a heading, number of referrals to the liaison psychiatric service in the Mater Hospital. And the liaison service refers to the psychiatric service that is provided to the rest of the general hospital, not the part that has the psychiatric unit, but the rest of the hospital, the medical wards and the surgical wards. And pre-COVID, for the 6 months from 2019 to January 3rd, 2020, there were 726 people referred to the liaison service. That's quite a high number. It is the largest in the country. Us and James's have the largest number of referrals to this service and to the self-harm service. And as I said earlier, these would be perhaps people coming in having gallbladders out or having heart transplants, for example. All the heart and lung transplant people have a psychiatric assessment routinely, but we do get referred people who are depressed or anxious as well. And since COVID started, the general admissions have declined. People aren't being, routine procedures aren't being done. Only emergency admissions are being done. So the number of patients, or the type of patients that are being seen in these wards, has changed significantly since COVID started. And that's because it's mainly COVID patients that are being admitted. And it's mainly COVID patients that are being referred to the psychiatrists as well. And again, for the past 3 months, we have had 373 COVID referrals, and that's approximately, for a 6-month period, the same as the referral rate that we had, or the referral numbers that we had to the liaison service before COVID. So the referral pattern has changed. The people we are seeing now are a somewhat older population because they are the most vulnerable to the COVID virus, but the numbers are the same. And it just goes to show that, just because people have COVID, they're not protected from mental health problems. We still need psychiatrists, and the teams of psychiatrists in the Mater Hospital where I work are as busy as ever. Now, what kinds of problems are we being referred by our colleagues? Well, people feel panicky when they know they have to get oxygen, and they're also panicky about the masks, and they can become very frightened. Masks are not pleasant things to wear for any of you who are using them. They can get very difficult and uncomfortable and hot, and difficult to breathe into after a few hours. There's the understandable and real fear of death. And particularly if you're so unwell that you need oxygen and assistance breathing, that can be terrifying. There's also the loneliness of not being able to see your loved ones, your siblings, your parents, your spouses, partners, children, whatever. Grannies can't come in to see you, and that's very lonely. The most common diagnoses that are being made in this group are adjustment disorders. This is different from post-traumatic stress disorder and depressive illness in that it's a less serious disorder, in that it's often self-limiting. Once people get used to the situation and adapt to it or adjust to it, the symptoms wear off. They don't actually respond to antidepressants. There's no evidence that they work even if they're given them. They sometimes need, and these patients sometimes do need, some tranquilizers to calm them down, like benzodiazepines, things like Xanax and Valium to calm them down. Most people are not presenting with post-traumatic stress disorder or depressive illness, despite the fact that being in intensive care in particular is is very frightening, but I'll come to that in just a moment. And of course, some people become unwell with the more usual psychiatric illnesses, including adjustment disorder like depression, for example, depressive illness and anxiety disorders. If they have had pre-existing ones, they may well decompensate when they are in hospital with COVID. Now, among outpatients, we're not getting any or very few new referrals. We're getting the occasional emergency referral to the outpatient clinics, but we can't do person-to-person interviews. And to be honest, we try and do telemedicine and use the new technologies like Zoom and Skype, and there are some ones designed specifically for medical use that can be used, but they're not in any way, shape or form the same as seeing somebody in person. And that is particularly true of mental health problems, for those with mental health problems, because you miss out on some of the body language. And words convey a lot of information, but they don't convey the totality of the information. And so the person's body language, for example, if their hand is trembling, you won't see it if they have it on their lap during the interview when you're doing it, say, by Skype. Whereas if you're with them face to face, you can see it when people when are anxious, they sometimes their feet start to shake, one or other of their feet start to shake. You miss all of those kinds of cues, and also the warmth that a person has and their enthusiasm, whether you think they're going to engage with the treatment you're offering, be it psychological or pharmacological. You won't be able to pick that sense up as easily from a technological guided interview. Now, what about the aftermath for COVID victims? Well, it's unclear what it's going to be, because this is a very new condition. It hasn't occurred before. The only thing we have to go on is the SARS virus, which of course didn't affect people in Ireland. And so we don't really have much that we can generalize to the western part of Europe in relation to this. People who've been in intensive care are the most risky. Intensive care is an intensely frightening experience, as well as being a caring unit. It's very frightening. Even when I go up to intensive care to see patients, the tubes, coming out of necessity that are emerging from people's bodies, the gurgling noises that you hear with the various electrical equipment, the bleeps, the noises, and the distress in people visiting. Now, of course, families aren't allowed to visit ICU during COVID, but even at the best of times, it's a very distressing place to be. And for those who have been there, after they come out of ICU and are either back on the COVID wards or discharged home, they will certainly be at risk, I believe. People will also be at risk from not having seen their families. And the loneliness, particularly for elderly people, we know that can trigger depression. So the elderly not seeing their own families, or indeed their neighbours or loved ones, people that care for them, will be a big stressor in the aftermath. They may actually, as well as that, have doubts about what will become of them. How will they cope when they go home after this life-threatening infection? Being confined is a huge problem as well, because sometimes when people are anxious, they'll walk up and down, and the exercise will actually relieve their anxiety levels and their distress levels. They'll meet other people on the corridor that if they know they can chat to them. But that's not happening. People can't wander the corridors anymore. They are confined to their rooms. And if they've got drips and various tubes coming out of them, motion becomes all the more difficult. I think people will be at risk for anxiety. They will be at risk for post-traumatic stress disorder and for adjustment disorder as they reorientate. I think they will be at risk for depressive illness, but probably less so than these conditions, although if they've had pre-existing depression, that will of course be relevant. Now, what about their families? Their families will suffer too. Those who are bereaved and who haven't been able to grieve properly, who haven't been able to kiss the loved ones just before the cast closes, who haven't been able to touch the hand of the loved one, they will be at risk for abnormal grief reactions and possibly depressive illness, because abnormal grief can tip over into clinical depression at times. There will also be the impact on them of job loss, if the companies and work they did has closed down, if the firms have closed down, and there will be accruing financial hardship that can also trigger low mood and anxiety. Now, these may or may not be full-blown depressive illnesses, but they will certainly be mood disorders of some sort, either what we would call depressive illness or adjustment disorders. There will also be the impact of them being lonely, not having seen family members, and of reorientating. And of course, the stress of it all, if they have a pre-existing condition like bipolar disorder or like depressive illness or an anxiety disorder, may trigger a recurrence because they haven't seen their family in a long time. And this may begin for them while their family are still in hospital and continue thereafter. And I am certainly seeing a little bit of that at the moment with people who have been well and coping and forbearing with the restrictions, are now finding it extremely difficult and they're relapsing in their illness, and that is clearly a worry. Now, there will be impacts on the wider society as well, in my opinion. There'll be the big impact of a recession. So even those who haven't had COVID and those who don't have any mental illness, we'll be seeing the same pattern as we saw with the 2008 recession, where there was a lot of mood disturbance resulting in self-harm, sometimes suicide, in depressed mood, sadness, general upset at it. We will see the impact of the return of drug dealers to the streets. So people will be taking more drugs again, and that will be causing relapses in those with pre-existing illnesses, and those who had psychotic illnesses previously will be particularly vulnerable, because these drugs can cause psychosis. Cannabis can trigger psychosis in the vulnerable, ecstasy, cocaine, MDMA. These can all trigger these very severe and dangerous illnesses. I think there will be the impact on marriages and relationships of being locked down and being housebound. And if marriages and relationships are in trouble, they will be augmented by being under the feet of that person all the time. So there will be an increase in marital problems. And of course, those exposed to domestic violence will be in even a worse state. And so these will impact on the mental health services throughout the land. The impact of working from home is beginning to cause problems. Initially, it was a bit of a novelty. Not having to drive to work was great, saving time, not being stuck in traffic, being able to work at home and do it in your own time. But that's beginning to wear thin now, as people are finding that there's no boundary between work life and home life. Some employers forget that their employees may not be sitting at their computers answering emails at 10 o'clock at night and getting annoyed when they're not. And I certainly had one person describe that to me yesterday, who said she got a call saying, why aren't you at the computer? And she gave the person, rightly, she gave them a short shrift. There's going to be the wider impact on social relationships generally, I believe, and in particular on neighbourhood relationships. I found it very worrying when this lockdown happened, and I wrote about it in my column in the Irish Independent, expressing concern about neighbours, turning into snitches and, reporting people for having gatherings in their back garden. And I think that that kind of thing that happened in Stasi land isn't a good thing for neighbourliness. I would like to think that neighbours would get closer, but sadly, I think this is going to impact significantly in a negative way on many neighbourhood relationships, so that neighbours who know that the people next door or across the road have reported them will suffer and impact adversely on society. And finally, there is the impact of the delay that some people may have opted for in seeking help for undiagnosed mental health problems. So, for example, if somebody is getting panic attacks, rather than going to their GP to get help for it, they will have delayed it because the GPs aren't seeing people and they don't want to go to the emergency departments to be seen in case they'll get the virus. So I think that group who have delayed consultation will be in difficulty. The other problem, and it's only a theoretical one, but it may arise. There are suggestions that the COVID virus itself has an effect on the nervous system, that it actually is neuro-infective, that it damages the neuroinvasive, that it damages the actual nerve cells in the brain. And it's also possible that because of inflammation, there will be damage to parts of the brain, at least temporary damage. And if it is neuroinvasive and it's actually going into the brain tissue, it could cause mental health problems like depression, or who knows, depending on where the parts of the brain that it invades. There's also the fact that, and this would apply probably more during hospitalization, if people aren't able to breathe, there isn't enough oxygen going to their brain, so they may get temporary confusion. But the long-term concern is the neuroinfectivity of the virus itself on the brain. Finally, I'm going to touch on frontline workers, and there is quite a lot of support for them in the Mater as in other hospitals. I'm describing here what's happening in the Mater hospital. There's a drop-in service run by some nurses with expertise and training in counselling and in mental health, but who are working on the general hospital side. And there's a drop-in service for them, or sometimes they make contact directly with the person on the ward. There's actually an office that they can drop into. And so far, since the COVID lockdown started, there have been 50 frontline workers accessing that, and it applies to any frontline workers. It could be domestic staff, nursing staff, medical staff, anybody. And simply when these nurses are going round the wards, checking that people are okay, or perhaps having been alerted by senior nurses that there's somebody on the ward who isn't coping very well, contact will be made by the person going to the ward and having a chat with them.